everyone. I'd like to welcome everyone to today's webinar that has been facilitated by the Zambia Pediatric Association. My name is Tello, or Dr. Siame Mumba. I am a pediatrician currently working within the Haematology Unit. And as we commemorate our Sickle Cell Awareness Month, which is this month of September, we did ask for indulgence from the Zambia Pediatric Association concerning a presentation on sickle cell disease. At this juncture, before we begin, I would like to recognize and thank the Zambia Pediatric Association Executive Committee that are on the call. And indeed, we do thank you for giving us this opportunity to highlight one of the pertinent issues that surrounds sickle cell disease. So this evening, we will have the presentation that will be done by Dr. Uzima Chira, who is a pediatrician and pediatric hematologist working within the university teaching hospitals under the Haematology Unit. On the call, we also have part of our team and our mentors and leads. That is Dr. Catherine Chunda Lioka, who is also on the call. So this evening, we'll be discussing management of acute pain in sickle cell disease. And just to note that the call is actually open to medical practitioners and the community and public alike. So this will be a very interactive session. We hope that either the medical personnel, but also the public and those interested parties can also come forth with the questions and discussion, just to ensure that we have a rich discussion as we advance the care of sickle cell disease in our population in Zambia. I think with those few words, I will proceed to ask Dr. Chua to proceed with the presentation. Thank you so much.
Thank you very much for that beautiful introduction. And I must say I'm impressed with the people who have taken time to sit on their computers, on their phones, and listen to this talk on the management of acute pain in sickle cell disease. So I have no disclosures to make for this presentation. And yeah, so let's begin today's talk. And we'll begin today's talk with a quiz, and feel free to type in your answers in the chat box. Good, so let's get to work. So our first quiz is as follows. In a sickle cell anemia, the mutant hemoglobin molecule undergoes A, polymerization under low oxygen tension, causing that changes the shape of red blood cell to sickle-like structure, or is it B, depolymerization under oxygen tension, causing that changes that shape of the red blood cell to sickle-like structure, or is it C, denaturization under high oxygen tension, causing the changes to the shape of red blood cell to a sickle-like structure, or D, denaturization? So the answer is A. So there's polymerization under low oxygen tension that causes the red blood cell to change its shape from a round donut-shaped red blood cell to a sickle or banana-shaped structure. So as a way of introduction, we're going to talk about blood. So we know blood is very important in that it provides oxygen and nutrients to all the tissues of the body, and also helps in taking away waste products away. Blood is composed of the cellular part and the liquid part. The cellular part consists of red blood cells, which carry oxygen throughout the body to help us produce energy and maintain our bodily functions. It also has white cells, which are very important and vital in protecting us from getting infections. We also have platelets, which are very important in stopping bleeding whenever we have injury to a blood vessel. And these cells, I must mention, are produced in a soft sponge-like structure in the bone known as the bone marrow. So sickle cell disease is an inherited blood disorder that affects red blood cells. It affects them in such a way that they change shape, and this has got major consequences in the way a patient will present to the hospital. Okay, So as I mentioned earlier, red blood cells are typically round, okay, smooth, and easily bend and live for 120 days. Whereas in an individual who has sickle cell disease, the red blood cells are sickle-shaped, sticky, and rigid. And because of this, they can cause complications as a result of blockage in the blood flow to tissues in the body. Not only that, the lifespan of red blood cells is shorter. A normal red blood cell will live for like 120 days, but the sickled red blood cells only live for about 10 to 20 days. And thus, patients with sickle cell disease tend to have chronic anemia. The inheritance of this condition is a result of inheritance of two copies of what we'd call the beta inheritance of two copies of the hemoglobin S from two parents. Okay, and so when a child has two copies of this gene, they'll have sickle cell disease. Whereas a parent who has a single copy of the gene are known as carriers or traits. So the basic pathophysiology is that when a child has two copies of this gene, the sickle hemoglobin undergoes polymerization when there is deoxygenation or there is low oxygen. Okay, these polymers make the red blood cell rigid, distort its shape, and cause the structural changes which will lead to damage of the red blood cell membrane. All of this alters the properties of this red blood cell. Okay, so this red blood cell typically when it's flowing through capillaries or small blood vessels in the body, they can cause obstruction. And when there's obstruction, there is no supply of oxygen to that particular tissue. And thus a patient presents with a painful sickle cell crisis. I must mention that the extent to which the sickle hemoglobin polymerizes is a primary determinant of the severity of the sickle cell disease. And so in patients who've got very high levels of the sickle hemoglobin, they'll have high severity of the disease. Whereas in patients who have a good amount of fetal hemoglobin, the fetal hemoglobin will kind of like reduce the concentration of your sickle hemoglobin, and thus they'll have less frequency of these pain crises and less frequency of other complications, which we'll look at as we go along in today's talk. So I talked about the inheritance. So for a child to have this sickle cell disease, you need both parents to be carriers of the sickle cell gene, right? So in any pregnancy, if a couple are both carriers of the sickle cell gene, there's a 25% chance that you may have a child with normal hemoglobin, which is called hemoglobin A or adult hemoglobin. In any pregnancy, again, there's a 50% chance that you may have a child who is a carrier, or there's also another 25% chance that you may have a child who's got sickle cell disease. However, it just depends on how the genes mix at the time of conception. So it doesn't necessarily mean that if you have 4 children, you're going to have 4 children this pattern, but you may have, for example, 4 children and all 4 kids have sickle cell disease, or you may have carriers. So it just depends on how the genes mix. But by and large, any couple that are both carriers have got a 25% chance of having a child with sickle cell disease. Now, sickle cell disease was first described by an American physician and a professor of medicine in 1910. Dr. James Herrick was a practicing physician in Chicago, and he first discovered sickle cell in his dental student who had emigrated to study in the United States. And he looked at a blood smear of this student and noticed sickled red blood cells. In the beginning, it was known as the Henrich's syndrome, but now we know it as sickle cell disease. And we've known this disease for over 100 years now. This brings me now to our next quiz. We can all get typing in our chat box. So the quiz is as follows. Sickle cell anemia is characterized by, is it A, lifelong hemolytic anemia? Or is it B, tissue damage and pain? Or is it C, premature death? Or is it D, all of the above? You have 15 seconds to type the answer in the chat box. Ten seconds. 5 seconds. Good, awesome. So the answer is D. So all of the above. So sickle cell anemia is characterized by long-standing hemolytic anemia, which is the breakdown of the red blood cells. There's also tissue damage or end organ damage. And of course, there's acute and chronic pain, and of course, premature death as a result of the disease. Which now brings me to this slide to talk about the pathophysiology of sickle cell disease. So basically, there are two main pathophysiological mechanisms that result from sickle cell disease. Okay, so one, you have a reduced lifespan of the red blood cells. Okay, so red blood cells are destroyed early in a process known as hemolysis. And when the red blood cell breaks down, there is release of intracellular contents. And one of the intracellular contents is the hemoglobin, right? Now, this hemoglobin molecule is a potent scavenger of nitric oxide. So nitric oxide is a chemical that helps our smooth muscles in the blood vessels to kind of dilate or become bigger, right? Now, with low levels of nitric oxide, the blood vessels tend to become smaller, and thus there's reduced blood supply, okay? And this can lead to what is known as hypoxia, or reduced oxygen delivery to the tissues, okay? In addition to the hemolysis, there is also obstruction. Remember, I talked about that red blood cells are round. However, in sickle cell, the red blood cells are sickle-shaped, sticky, and rigid. And so when the red blood cells are passing through these small capillaries or blood vessels, they stick to one another. They can also stick to the walls of the blood vessels and cause obstruction. And so the distal part of that tissue will not receive any oxygen and nutrients and will tend to die, right? And these patients will present with painful crisis. Now, this obstruction can occur in any organ of the body. Think of any organ in the body. For example, in the brain, they may present with a stroke. In the chest, they may present with acute chest syndrome. In the bones, they may present with pain crisis. They may also present with chronic leg ulcers, etc., which we'll look at in detail. Now, with regards to pain crisis, there are a number of molecular and cellular processes that contribute to each vaso-occlusive crisis, which we'll look at. To begin with, a vaso-occlusive crisis is a recurrent episode of severe pain, which is experienced by patients with sickle cell disease. The cause of this event is due to blockage in the small blood vessels in the tissues. And this is caused by the stickiness of your red blood cells, by the red blood cells sticking to one another and sticking to the walls of the blood vessels. Okay? When this obstruction occurs, there is ischemia to the tissues. In the bone and bone marrow, this may lead to pain crisis which a patient will present with. And this pain is quite severe, and it may affect the way the patient lives their day-to-day activities. Okay? The clinical manifestation of this obstruction can be quite explosive, and patients require immediate attention. In fact, when a patient presents to the health facility, it is important as healthcare workers that these patients are triaged and that receive immediate attention once they present to the facility. Okay? These pain crises may be accompanied with fever or may be accompanied with an increase in the white cell count. And sometimes, if not managed adequately, may present with complications, okay? They may have a single joint being involved, or they may have multiple joints being involved, okay? And typically, they have a rapid onset of this pain crisis. The pain crisis is also associated with inflammation, and may be reoccurring. And if not well managed, the patient may end up having end organ damage. And this is important as healthcare workers. We ensure that the child with sickle cell disease is adequately managed. And once they're treated, preventive measures are put in place to ensure that this patient does not have frequent pain crises. Now, vaso-occlusive crisis can have quite a devastating impact to patients with sickle cell disease. And this can be categorized as short-term or long-term. The short-term impact includes children who have less time to school, and this will affect their school performance. For parents and adult patients, they may not have time to go to work that often, and so this may impair their work. Not only that, the frequent visits to the hospital or health facility may take away the time for them to have with family and friends, right? In the long term, there is potential for severe acute and chronic complications. Amongst the acute complications include acute chest syndrome. They may have acute kidney injury. They may present with stroke, be it a hemorrhagic or a non-hemorrhagic stroke. In boys, they may present with priapism. In the infancy and young, and below the age of 5 years, they may present with splenic sequestration, and they may also have hepatic sequestration. In adults particularly, they may end up developing chronic pain, which is quite difficult to manage. So with age, particularly with increasing age, chronic end organ damage is a major complication that we need to look out for. And in particular, patients with avascular necrosis of the femur, or patients who may present with end-stage kidney disease. Let's look at the clinical presentation. How do these patients present? Typically, they'll present with severe pain, okay? So as a healthcare provider, looking at a patient who's presenting with pain, you want to find out when the pain started. You want to find out the location of the pain, the intensity, the level of distress, and the impact that this pain has on the patient. And there are various pain scoring tools which can be used for assessing the severity of the pain. In addition, you want to find out whether this pain is similar to a previous sickle cell disease pain that a patient may have experienced. Okay. By and large, many patients with sickle cell disease may try analgesia at home. So they may have, for example, taken paracetamol, or they may have taken brufen, they may have taken diclofenac to help with the pain. Okay. And if the pain does not work, or if the pain medication does not work, then they present to the facility for further management. Also, we want to find out if there are any associated symptoms. Okay, so they may have a fever, for example, or they may have evidence of dehydration. Now we're going into the hot and dry season in this part of the world. And so it's important for us to assess the level of dehydration, right? They may also have signs of respiratory distress. So fast breathing, nasal flaring, okay? In addition, you want to find out their drug history. Are they taking hydroxyurea or not? If they're taking hydroxyurea, I want to find out, is the dose correct, okay? Or is it the optimal dose, right? You also want to find out if there are any other allergies to medications, okay? And what has worked for them in the past when they come in with a pain crisis. When it comes to a physical examination, it's important that you assess the vitals. So respiratory rates, the heart rate, the blood pressure, your oxygen saturation also is very, very important. And a patient presenting a vaso-occlusive crisis, you want to ensure that the patient's oxygen sats are above 95%. If below, the patient may benefit from oxygen supplementation. In addition, you want to assess the hydration status. So look at the mucous membranes, assess their pulse, okay? Assess the degree of pallor. And this is very important. If a patient presenting with a vaso-occlusive crisis and are severely pale, you may want to avoid giving them IV fluids because it may actually worsen the hemodynamic status, okay? Assess for evidence of infection, so they may present with fever, okay? Inspect the sites of pain, okay? Look out for things like swelling or erythema, okay? Because also in addition, you want to rule out acute osteomyelitis. And if they have acute osteomyelitis, you want to give this patient appropriate antibiotics to cover for organisms causing acute osteomyelitis. Assess the cardiopulmonary status, so ensure that you know the blood pressure, you know the pulse. In young children, particularly those below the age of 5, you want to assess if they have a spleen, okay? Because if they have the spleen, it may be that they may have acute splenic sequestration or they may have hypersplenism. In addition, you want to assess the neurological status, so document the Glasgow Coma Scale, document the level of sedation if they have been given any sedating medications from the referring facility, and also assess the level of orientation. Now, once this is done, then you can begin with managing the patient for a vaso-occlusive crisis. In terms of diagnostic evaluation, you want to ensure that you do your full blood count with a differential and a retic count. If you suspect they may have an infection, do a blood culture. In Zambia, it's important that every child who's got sickle cell disease presenting a crisis do a malaria test, either an RDT or a malaria parasite slide, right? Do a group and cross match, particularly if they're severely pale. If they're presenting with right upper quadrant pain or epigastric pain, it's important also to do LFTs and assess for either cholelithiasis or cholecystitis. With regards to imaging, consider a chest X-ray if there's a presence of fever. I also want to do radiographic imaging, particularly if you suspect they may have localized bone pain. Okay, this may be suggestive of acute osteomyelitis or aseptic arthritis, or they may have aseptic necrosis. And this must also be done in consultation with the orthopedic surgeon. This now brings me to our next quiz, so we can get typing in the chat box. So the quiz is as follows. How soon should a child presenting with sickle cell disease pain crisis receive analgesia? How soon should a child presenting with a sickle cell disease pain crisis receive analgesia? Is it A, 30 minutes within hospital arrival? Or is it B, 45 minutes within hospital arrival? Or is it C, 60 minutes within hospital arrival? Or D, the time interval depends on the severity of the pain? All right, there we go. So a patient presenting with sickle cell pain crisis must receive analgesia within 30 minutes of hospital arrival, okay? Just out of curiosity for the healthcare providers on this talk, just take time to reflect at your various institutions. How long does this usually take in your hospitals? You can type the answer in the chat box so I just get to see how we manage patients presenting with a pain crisis in your facility. So in your various facilities, how long does it usually take for a patient presenting with a pain crisis to get analgesia? You can type in the chat box. Okay, so Patrick Luhanga says less than 30 minutes actually. Okay, that's good. Okay, KMH faster than 30 minutes, that's good. Natalie says within 15 to 20 minutes. Okay, good. Okay, Andrea says less than 30 minutes, that's good. Lloyd says within 10 minutes upon arrival, that's excellent. Okay, that must be Manasoko within 30 minutes. Mavuto says within 10 to 15 minutes, that's very good. So it's very important that Emilia says within 30 minutes, that's very good. So it's very important that when a child presents in a pain crisis, this must be treated as an emergency, right? And so you want them to get urgent medical attention because any delay will lead to end organ damage, right? And typically, a patient presenting in a pain crisis, they'll present with severe pain. And like I mentioned, most of them may actually take some analgesia at home and present to a level or to a next level of care when the pain is so severe that they cannot manage at home. Good. Now, how do we manage a vaso-occlusive crisis? So it is important as healthcare providers that we involve the patient in the management, okay? And this is very important, right? And in terms of management, there is one providing of opioid or non-opioid analgesia, and this will depend on the level of pain and the patient's medical history, okay? And this analgesia must be offered within 30 minutes of presentation and monitor the response, okay? And it's very important to see whether your interventions that have been put in place are working or not. And if they're not working, you want to find out why, right? Thirdly, you want to provide them with hydration, which is very important. And this can be either oral hydration or IV hydration, okay? And again, monitoring is very important to avoid fluid overload in these patients, okay? Listen to the patient, pay attention to the patient, and each patient that presents to facility presents differently, right? Assess the causes and consequences of the vaso-occlusive crisis and provide supportive care, which we'll look at. Now, a pain crisis has got 4 stages, right? And these stages can last on average like, about 10 days, okay? And in the beginning is what is known as a pre-droma phase. So in this phase, a patient may experience like symptoms such as numbness or paresthesia or X, kind of like burning sensation or pricking sensation in the hands, legs, arms, or feet, okay? Or what is known like an aura, okay? And some may be asymptomatic, right? And then about a day or two later on, they may present in what is known as the initial phase. So in the initial phase, this is where now the pain reaches its peak, as can be seen in this graph, okay? And if you look at the pain scale, their pain scales like 9 to 10 out of 10, okay? This is where now like the pain is really established and the pain is quite severe, okay? And the patient also has increased anxiety during this phase. And so for us as healthcare providers, it's very important that we begin treating these patients early to avoid them getting to what is now the 3rd stage of the pain crisis, which is the established phase. During the established phase, pain maintains its peak, okay? They may also have signs of joint effusion and inflammation, okay? And this is the time when you may have onset of complications, right? Complications such as acute chest syndrome, multiple organ failure, okay, relapse, and if not managed, it can be quite fatal and lead to death, okay? But if the pain crisis is managed adequately, you're given adequate analgesia, adequate IV hydration, they go into what is known as the resolution phase where the pain crisis is resolved and the patient can be ready for a discharge from your healthcare facility. Good. Now let's look at the management strategies. So we have got adjuvant therapy and non-pharmacological therapy. We've got hydration. We have oxygen supplementation to maintain oxygen saturations above 95%. We'll look at analgesia, and we'll look at blood transfusion in selected patients. So with regards to non-pharmacological treatment, this is very important. And you can use various strategies. You can either use virtual reality, you can use audio-visual cues, okay, to help the patient relax and take their mind off the VOC. You can also use things like meditation. You can also use massaging, so warm massages to the area that is affected. And you may provide rest for the patient as well. I must mention, however, avoid cold, as cold can actually worsen the vaso-occlusive crisis. With regards to hydration, it's important that you establish IV access, right? And you ensure that the IV access is patent. Provide adequate amounts of fluid for the patient. And the fluid of choice is 5% dextrose in normal saline. And this is given at about 1.5 times the maintenance fluid, provided that there is no cardiopulmonary compromise, right? Ensure the patient is not severely pale and you give your IV fluids. Again, when giving IV fluids, it's very important that you monitor the patient to avoid fluid overload. If it's a patient presenting with acute chest syndrome, you want to give only about 2/3 of the maintenance fluid, again, because of risk of overloading the patient with fluid. Oxygen supplementation is very important. You want to increase the oxygen carrying capacity of red blood cells and improve oxygenation of the affected tissues, right? So aim for an oxygen saturation above 95% to ensure that the patient recovers quickly. In terms of analgesics, so it's very important we give it by the mouth, by the clock, by the ladder for the individual patient, and let's pay attention to detail, okay? So it's very important that you give the patient adequate analgesia. If it's 4-hourly, we should stick to the 4-hourly time regimen, okay? Let's follow the WHO step ladder with regards to pain management, okay? And each individual is different. So it's very important that you pay attention to an individual patient and pay attention to the detail, that is the mode of administration of your analgesics. So we have the WHO step ladder approach to managing a vaso-occlusive crisis. So for mild VOCs, you may provide the patient with paracetamol and an NSAID. NSAID may be either brufen or diclofenac. And be mindful if you're giving an NSAID, ensure that it's given with food to avoid the complications of them developing stomach ulcers. And this may be provided with adjuvant therapy, okay? If they have moderate pain, you may escalate to tramadol, okay? But in addition, provide also adjuvant therapy. If a patient has severe debilitating pain, you want to escalate to your morphine, okay? So provide morphine or opioids plus adjuvant therapy. So this is the mode that we use with regards to managing a vaso-occlusive crisis. So in terms of dosages for children, so for NSAIDs, brufen, your dosage is 5 to 10 milligrams per kg per dose. And like I mentioned, this must be taken with food. Your paracetamol is 15 milligrams per kg per dose. For tramadol, it is 50 to 100 milligrams TYD per oral. And tramadol, must be given in children above the age of 12 years, and also provided that their renal function is adequate. For those presenting with moderate to severe pain, ensure you provide your opioids, in this case morphine, so 0.1 milligram per kg per dose IV, or if you have the oral formulation, it's 0.2 to 0.4 milligrams per kg per dose. The maximum dose that you can give for morphine is 10 milligrams per dose. Morphine may cause constipation, so it's important that you provide a laxative, so either lactulose or polyethylene glycol to counteract the effects of morphine, and mainly constipation. Good. This now brings me to my next quiz, and the quiz goes as follows. A blood transfusion is indicated to treat a sickle cell disease vaso-occlusive crisis. Is it A, true, or is it B, false? So the answer is B, false, and we're going to look at the rationale behind this, okay? So, red blood cell transfusion is not indicated in all patients presenting with a vaso-occlusive crisis. And this is very important for us as healthcare workers to bear this in mind. And the rationale is that when you're going to transfuse a patient with sickle cell disease, actually may end up causing hyperviscosity of blood. And thereby may actually worsen the vaso-occlusive crisis, right? However, in a patient that presents with acute chest syndrome, or they have a drop in their baseline hemoglobin, they may benefit from a simple blood transfusion, okay? In facilities that have excellent transfusion, this can be quite helpful, in that it will help bring the hemoglobin or the sickle hemoglobin to less than 30%. Must mention, however, when you do these modalities, it's important that the hematocrit does not exceed 30%. Not only that, blood transfusion is not recommended for chronic monthly transfusion in patients presenting with recurrent acute pain. Good. Now, having managed the vaso-occlusive crisis, the pain is no longer dependent on your opioid analgesics. The patient is tolerating drugs orally, and they are on the road to recovery. We plan to discharge the patient. So what's the discharge criteria? So one, a patient may be discharged if they are tolerating fluids and medications by mouth. Pain control is adequate with oral medications, and the concurrent problems are resolved. For example, if they present with acute chest syndrome, the acute chest syndrome is resolved, or they're presenting with an infection, that infection has resolved. Then the patient may be discharged. It's important as you are discharging the patient that you give them adequate counseling on routine care, on routine follow-up, and on adherence to their usual medications. So their folic acid, their delta-prim, which is antimalarial prophylaxis, hydroxyurea therapy. For those below the age of 5 years, BNV prophylaxis, right? In addition, you want to also give them self-care strategies and psychosocial support that are very important, which they can use at home to help them prevent recurrence of pain. So I've talked about hydroxyurea therapy, which is very important, okay? It's currently the only disease modifying drug that is available, okay? And it's a wonderful drug for patients with sickle cell disease. It's important that you take their folic acid. It's important that you review their under 5 cards, look at their vaccination history, ensure that they're fully vaccinated as per the Zambian childhood vaccination program, and ensure that you've aggressively managed the infections, okay? If they're below the age of 5 years, ensure that they're on BNV prophylaxis, okay? Ensure that also they're getting their anti-malarial prophylaxis, okay? Discuss with them also mind-body relaxation techniques and distraction techniques, such as listening to music, taking walks, you know, playing their favorite games, okay? Also encourage them about training them about coping skills and abilities to cope with pain. Also, it's important for them to enhance their social support networks, so they should be linked up to the various sickle cell disease groups, where they can interact with their fellow patients and see how they're coping and see how they're managing their disease, okay? And it's important for those who are in school, they continue to go to school so they get their education. And also ensure that you give them a review date when they should come for their usual follow-ups. Or if they have any concerns, any fever, any pain, they should come back to the nearest health facility to get urgent medical attention. So I would like to end my presentation with this beautiful picture, which I got a couple of years ago. This is a picture of my neighborhood where I would go for my morning runs. And I found it to be quite impressive. And it was kind of motivating for me to go to my early morning runs and seeing how the leaves would turn to yellow, orange, green. It's breathtaking. Thank you so much.
Thank you so much, Dr. Chira. That was a very interactive and enlightening session. We have about 19 minutes to the top of the hour. So at this point, I'll invite questions. I'll ask that if you have a question that you kindly raise your hand. However, while we have some people raising their hands, there are actually some questions in the chat box as well that I will proceed to read. So maybe first we can have the first question from Dr. Chiza. You can go ahead.
Thank you very much for the presentation, Dr. Chira. My question was with regards to virtual reality and audiovisual relaxation. I just wanted clarity to what tools and specificity, to be more specific with the virtual reality tools we're using? Are we using those headsets that we see on TV where are we supposed to, like, is it something like that? Because I'm trying to figure out what you meant exactly by that. Yeah, thank you.
Okay, before Dr. Chira comes in, maybe I can just read 2 more questions so that you can tackle 3 at a go. I think there was a question that came in concerning the hemoglobin lower by how much from the baseline hemoglobin. So I think it was the time we're talking about the transfusions. And then while we're talking about transfusions, is there a role for blood transfusion or exchange transfusion for a prolonged VOC? So maybe before I proceed to have the next 2 questions and read a few questions, maybe you can answer those 3 questions, Dr. Chira.
Thank you very much for those great questions. So with regards to adjuvant therapy or, non-pharmacological therapy, basically I was referring to what you have at your facility. So you may use, for example, TV. You may have a TV in your ward where a child may be watching a cartoon. That will tend to help them remove their focus on the VOC. So not necessarily having those, latest state-of-the-art gadgets. So what you have at your facility may help with non-pharmacological therapy. And then regarding blood transfusion, so if a baseline, so typically when you're following up a patient, they may have a baseline hemoglobin, right? And so if you have a drop in the baseline hemoglobin by more than 2 grams per deciliter, right? Or if they have a prolonged VOC, typically we say more than 4 days, that would warrant them getting a blood transfusion. Again, when giving them blood transfusion, it's very important that you do not exceed the hematocrit of 30% to avoid them having hyperviscosity of the blood. Thank you.
Thank you so much, Dr. Chira. We have 3 questions in succession. So Dr. Marsden, then Bernard Njelesani, and Tetson Mwanza.
Thanks, Dr. Chira, for the great presentation. I have a question on kids that we see with sickle cell trait. We've been seeing this 11-year-old girl who has been complaining of joint pain, mainly in the knee. And, we ruled out all sorts of rheumatologic causes. And the only thing really is that she's a sickle cell carrier with a HbS of 37%. So my question, and range of motion, no swelling, nothing. So my question is it possible for certain kids who have sickle cell trait to present with joint pain significant enough to cause discomfort and them seeking pain relief?
Thank you very much. This is Bernard. Dr. Chira, I think great presentation. I can say that I have been hearing about sickle cell anemia for some time, since time immemorial. But my question is that, are there any ongoing research initiatives in this area aimed at addressing and mitigating the impact of the sickle cell disease? I ask this question in light of technological advancements that have made headway in research and innovation, and it is more accessible this time around. So while managing the symptoms of the disease is quite important right now, what motivates every one of us, though I'm not a doctor myself, to push the boundaries beyond a fundamental understanding of sickle cell disease?
Thank you. Thank you so much, Dr. Chira, for the presentation. My question is, do we have information on the magnitude of opioid addiction amongst sicklers? And if so, do we have any systemic plans to curb this problem? Thank you.
Thank you. Dr. Chira, you may answer the 3 questions.
Thank you very much. So I'll begin with Dr. Marsden. So we are seeing now with new research going on that some sickle cell carriers or traits are actually manifesting symptoms of sickle cell disease. Okay, under certain conditions. So certain conditions of stress, such as severe, or should I say extreme physical exertion. And so that patient may actually, because of the physical exertion, may be exhibiting symptoms of sickle cell disease. So if a patient presents in that manner, I would recommend that actually you manage them as a VOC by providing them with adequate analgesia and hydration to ensure they get out of that crisis. So I would say that not much has been done about it, but we're seeing that there are a number of sickle cell traits, sickle cell traits presenting with such kind of vaso-occlusive crisis, similar to what a patient with sickle cell disease may present with. Secondly, Bernard talked about therapies. So there's a lot of ongoing research now. In fact, now in the sickle cell world, these are exciting times for us because we're seeing a lot of research going on into the disease, a lot of new discoveries, a lot of newer therapies, right, which are being tried on, and some are now available in the market, okay? Just to mention but a few, some of the newer therapies include granizumab, which is a P-selectin inhibitor, so targeting the different pathways of the disease process, okay? So this P-selectin inhibitor is very important and is indicated in patients who have frequent pain crisis, who have not responded to our usual therapies, including hydroxyurea therapy, right? We also have now gene therapy, which is being tried out, and we hope that these trials also be available in the country so that we can see how this would work for our patients. Tetson regarding opioids. So I do not think I've come across any study that looks at the magnitude of patients having addiction to opioids. But by and large, we do see a number of patients, particularly those who have been exposed to pethidine, right? And I must mention here that pethidine is not indicated in the management of pain crisis because we've seen a number of patients have addiction to pethidine and requiring therapy. So I've not come across any study to look at the magnitude of opioid addiction in the country.
Thank you very much. Maybe before I read the questions in the chat, Dr. Chunda, you have your hand up. May go ahead.
Thank you very much, Dr. Taylor. Thank you, Dr. Chura, for that very clear and very concise presentation. I thought just to go back on some of the questions that you have answered. There was a question about a patient who's trait and who's exhibiting symptoms of a sickle cell disease patient. So it has actually become more and more evident that some patients, yes, indeed, who are carriers, may actually not have the normal physiology of what you'd call a normal person who does not have sickle cell disease. And so they are actually advising that, as Dr. Chura said, you actually treat them as such when they present. The other side of the coin is that you might actually be dealing with a patient who has sickle cell disease, but you're just not able to diagnose the other part of the sickle cell. That is abnormal. Remember, the sickle cell is HBS, S or HBS with something. So not all diagnostic tools that we have are able to actually evidently give the other abnormality that the patient has. So that in your test, you might actually just be finding the S, but not really identifying what the other abnormal hemoglobin is. So that could be the patient you are dealing with, so that such patients actually need you to do HPLC on them to actually identify what sickle cell disease we are dealing with in that patient. Of course, we know most of our patients are HBSS, but it is possible that they could be HBS something. So that is just something that we need to keep in mind. And also in terms of curbing the burden, which seem to be increasing, of sickle cell disease, of course, this is something that has to be dealt with as a community. Apparently, sounds very simple, but something I believe that has eluded us. Until we can control the carriers, marrying carriers, and having children, will not be able to reduce the number of sickle cell disease patients that we have. So for those, of course, that are born with the disease, what we should be working on is diagnosing them early, beginning to manage them early, and then also ensuring that they develop complications if they do quite late. So that is the way I would say the sickle cell community has gone in terms of trying to care for this problem, which we seem not to be able to control in terms of producing more with sickle cell disease. Okay, and then there was also a question on the, what was that? On the addiction, okay? So indeed, yes, there could be an element of our patients getting addicted to the opioids that we give them, but we should also note that we need to address their pain adequately. Pain is the one thing that brings patients to the hospital quite often. It is also the one element which we don't manage very well and makes patients not come and seek other ways of managing themselves, and in the end, actually getting addicted. So let us also make sure that we actually manage the pain very well in the patients, which is why we deliberately thought we should discuss management of pain in sickle cell disease patients. Thank you.
Thank you very much, Dr. Chunda. But there's some pertinent questions that have been asked in the chat. And if you allow me, I have summarized them in the interest of time, Dr. Chura, so that those can be addressed. So I think they are really around the medication and drugs that are used in sickle cell. So around hydroxyurea. The question is when does one start and how early can it be started if it's available? And when does one stop the hydroxyurea? Is it advisable to give it on alternative days? And are you able to highlight the mechanism of hydroxyurea in sickle cell disease and also highlight any recorded cases of side effects such as malignancy? On Delta Prim, when does one start? And speaking about malaria prophylaxis, when there's no Delta Prim, how often can you give Fansidar? And then lastly, on PenV for the drugs, how long should it be given for, and is it indicated for every patient? And if I might throw in one on the blood transfusion, someone asked, is it indicated for all patients that present with a cardiovascular accident? And then I think after you respond, then I'll ask Dr. Somwe to come in with his question. So Dr. Chua, please go ahead.
Thank you very much. That's a loaded question. I'll try to answer each one at a time. So I'm going to begin with hydroxyurea, right? Like I mentioned, hydroxyurea is currently the only disease-modifying therapy available for patients with sickle cell disease, okay? And it is FDA approved. The recommendation is that we start hydroxyurea therapy in any child who has been diagnosed with sickle cell disease from the age of 9 months. And a number of studies have been done showing how safe it is to begin hydroxyurea therapy. And one study is the baby hug study, right? So hydroxyurea basically is an anti-cancer drug, okay, which was discovered in the 1800s, right? However, at a lower dose, it is very beneficial for children and adults with sickle cell disease, okay? Basically, it causes inhibition of DNA synthesis, thereby interfering with the synthesis of ribonucleic acid of a protein, okay? So in this case, with regards to sickle cell, it helps in one, it increases the baby hemoglobin, okay, or the fetal hemoglobin. And the higher the fetal hemoglobin, the less frequency of vaso-occlusive crisis and end organ damage. And typically, when we start a child on hydroxyurea, excuse me, our target is to reach a fetal hemoglobin level of 30%. And so when a patient has been put on hydroxyurea therapy, we do HB electrophoresis every 6 months to monitor to see that we are actually winning. Okay? Hydroxyurea, like any other drug, has got side effects. So they may have nausea, they may have discoloration of the nail beds, they may have non-specific rashes, okay? They may have also what we call reduced production of certain cells in the bone marrow, so red blood cells, the white cells, or platelets. However, when you put a patient on hydroxyurea therapy, we do monitor their counts. At each visit, we do a full blood count, okay, to ensure that we are within the parameters that will be acceptable. In the over 20 years of use of hydroxyurea, there's been no recorded side effect of malignancy in patients who have been put on this drug. So it's a very safe drug and a very wonderful drug. And once a patient has been put on this drug, they take this drug for life, okay? And it's important that any patient on hydroxyurea therapy, they adhere to a therapy in order to ensure you see the maximum benefit from this drug. The next question is regarding PNV prophylaxis. So again, any child diagnosed with sickle cell disease must be put on PNV prophylaxis. So begin from infancy up to 5 years. However, in a patient who has undergone splenectomy or a patient who has repeated episode of invasive pneumococcal disease, they may want to continue PNV prophylaxis for life, okay? So we stop at 5 years in those who have not had any splenectomy done or they have not had any repeated severe invasive pneumococcal disease. And they must have received their full complement in terms of their pneumococcal vaccination, okay? Malaria prophylaxis. So malaria affects patients with sickle cell disease adversely. And so it is important that they get malaria prophylaxis, considering that also that we are also in a malaria endemic country. And so the sickle cell guidelines state that we provide deltaprim as prophylaxis for patients with sickle cell disease. The dose for deltaprim is, so for those below the age of 3 years, we give a quarter tablet, or if it's a liquid formulation, we give 2.5 mils. Those between the ages of 3 to 10 years, we give half a tablet, or 5 mils if it's a liquid formulation. And then 10 years and above, they get 1 tablet or 10 mils, and this tablet is given once every week. I must mention that the tablet of deltaprim consists of pyrimethamine and dapsone. Okay. The other question was regarding if you don't have deltaprim, you may use Fancida. So I know that some facilities they use Fancida. I'm just not sure of the dosage of Fancida. Maybe Dr. Chunda may help me with the dosing of Fancida. But the recommended guidelines for our country is that we use deltaprim.
Yes, you have answered most of them, and maybe as Dr. Somwe comes in, there's just one more about an indication for, is blood transfusion indicated for every patient that presents with a cardiovascular accident? Professor Somwe, you may.
Thank you, Telo. Thank you for the team, Catherine, Uzima, and yourself. Very well done. I think this is a very important topic. Just quickly, mine is a comment, and I think Uzima is aware of this. I work in a surgical hospital, not a surgeon. So we've had sicklers who've been taken to theater and who've developed complications after the surgical intervention. And I was very pleased to discuss with Uzima, and he shared the TAPS paper. The TAPS paper showed that preoperative transfusion reduces the risk of post-op complications. My request to you is that I know we can share the TAPS paper. Is it possible that the unit at the Children's Hospital could come up with a little write-up, a page or two, on pre-operative management of sicklers, so that this is distributed all over the country? Because I'm sure sicklers will have this problem wherever they are if they are not adequately prepared before going to theater. Thanks. So it's just to see whether we could, it takes time to read the TAPS paper. It's quite an extensive paper, but could we come with a very small diagram like, or just a little write-up on pre-op preparation, especially pre-op transfusion? Thank you.
Thank you, Dr. Somwe, for that. Yeah, I remember we discussed this patient. Yeah, so from the TAP study, they found that if a patient who has not been adequately prepared, so what I mean is a patient who is about to undergo major surgery, and in particular, that involves general anesthesia, they must receive a blood transfusion to increase their oxygen carrying capacity, right? And so we want to optimize their hemoglobin. If they don't receive a blood transfusion, they're at risk of having major complications, including acute chest syndrome, stroke, and even fatality. And so I think it's important, like you've indicated rightly, that we should probably start by making a short, maybe a short guideline that we can circulate to all the pediatricians and surgeons that before a child with sickle cell disease is about to undergo surgery, that their hemoglobin is optimized to avoid those adverse events. And then just regarding the other question, I must mention that blood transfusion is not indicated for every patient presenting with a sickle cell disease crisis. Okay, only when they have a prolonged VOC that is more than 4 days, or they have a drop in the hemoglobin more than 2 grams per deciliter, or they're presenting with acute chest syndrome, then they would warrant a simple blood transfusion. However, in facilities with an exchange transfusion, you may want to use that facility by providing them with exchange transfusion with a target of reducing their sickle hemoglobin to less than 30%.
Thank you very much. Just as we wind up, I think the question on the whether it's advisable to give hydroxyurea in alternate days was not, I think, clear.
Oh, great. Thank you, Patrick. So with regards to hydroxyurea, it's quite a challenge with regards to dosing, right? As you know, the hydroxyurea formulation in the country comes as a capsule, and the capsule is 500 milligrams, right? And so when dosing a patient with sickle cell disease, and this may be a topic for another day in which we can discuss how to dose hydroxyurea, we calculate the dose over a 1-week period, so from Sunday to Saturday, right? And depending on the dosing, you may find yourself actually giving the dose either on alternate days, right? Or if you've got access to a pharmacist who can compound it in multivit, then you give it every day. So it just depends on your availability of a pharmacist to compound the drug. If there's no one who's available, you may end up giving it on alternate days, but provided that the calculated dose is given or is calculated over a 1-week period. So in some situations, you may give it an alternate dose regimen.
Thank you so much, Dr. Chira. Dr. Chunda?
Just to come back on prophylaxis, the recommended chemoprophylaxis drugs for use in sickle cell disease are actually mefloquine and progranil. The mefloquine can be given daily. No, the mefloquine is given weekly, whilst the progranil can be given daily. Fancida is actually not among the drugs that, if you look on the international recommended drugs, it's actually not there. Neither is the Delta Prim that we are using, because they've also documented some severe side effects in some patients. And in fact, if you look in the BNF, It's actually not there. Why we continue using it is that, of course, it used to be used some time back, and then it is a cheaper drug for us to use. So that's the only reason really that why we are actually using the Delta Prim. What we're supposed to be using is mefloquine and progranil, which are quite expensive. Going back to Dr. Somo's question about preparation of patients for surgery. Surgery in itself is a stress on the patient, and we know that any stressor, including emotional stress on patients, mental stress on the patient is something that might actually tip the patient to experience a VOC, even as severe a VOC as having a stroke. So in terms of preparing the patient, really, we have to prepare the patient beyond the physical transfusions. The patient has to be prepared psychologically, mentally, so that those things are also not triggers. And I believe in our guidelines, we have put something from the surgeons about how patients actually need to be prepared for surgery, whatever surgery it is they're undergoing. And they're also even categorized in terms of, surgery that you'd consider minor or major surgery. So that with the major surgeries, indeed, I think you need to transfuse such a patient, because during the surgery itself, you need to make sure that the patient is being adequately perfused, because under perfusion from the delivery of oxygen during the surgery itself is something that can compromise the patient. What was the last question that you wanted me to comment on?
I think it was on the Fancida. I think that one.
Okay, I think you've
Yeah,
clarified.
so Fancida is not used. And hydroxyurea you can begin to use the hydroxyurea as early as 9 months. But as you continue giving the hydroxyurea, as your patient gets into adulthood, you need to consider issues of fertility to the patient. If they're going for pregnant, you may want to hold off the hydroxyurea at the time that they are considering falling pregnant. The same with the man who wants to have children. Those are times that you may have to consider withdrawing it, but it can be used lifelong.
Thank you, Dr. Chunda and Dr. Chira, and everyone for those very enlightening questions. This, I think, and indeed has been a very rich discussion, and has been warranted by, I think, what is prevailing on the ground. As has been said, we have both medical professionals on the call, and we also have patients, warriors, and carers as well. And we thank you for such an interactive session. We have gone 11 past the hour, so I think we will need to close now. So as we end, Dr. Soma, your hand is still up. Maybe I'm not sure if that was the previous one, or you have something else you wanted to say.
Sorry, I forgot to lower my hand. Sorry.
All right, thank you very much. All right, so I think thank you so much, and there's been a lot of gratitude that has been expressed to the presenter for such a clear presentation, and even to the responses that were also given from the team. The recording will be shared, and from the ZPA team, and I think they will be able to give more details. So from us, from the hematology team, as I hand over back to Dr. Zulu. Dr. Zulu, you have your hand up. Would you like to say something now, or can I finish and then you come in?
Please finish.
Christina? All right, thank you. Yes. So from the hematology team, we are grateful for this opportunity that Zambia Pediatrics Association has given us to speak about sickle cell disease as we are raising awareness. This awareness actually does start with each and every one of us that knows something. So we need to spread the word, talk about sickle cell disease. We need to ensure that our children, our people in our homes, teenagers, friends are screened for sickle cell disease. And those that do have sickle cell disease that we know, we encourage them to seek health care and to seek it correctly, and also to dispel some of the myths that are out there in the community as well. So this is something that I would implore each one of us to do. So my name is Tello. Thank you so much. And I hand over back to ZPA by Dr. Christina Zulu. Thank you. Bye-bye.
Thank you so much to Team Hematology. This was really great. I'm sure everyone agrees. A few announcements from ZPA. Our next scheduled monthly webinar is going to be by the National Heart Hospital on the 27th of September. So please look out for flyers for that. We will also be having our scientific conference and AGM on the 24th to 25th of November in Osaka. Venue and further details will be announced soon. So just keep an eye on our page and the mailing list. And lastly, once our graphics team and video editing team is done with editing this video, it will be posted on our YouTube channel. So you can look for us there and look out for the link on our Facebook page. We have a new Facebook page. We had the last one was shut down due to proprietary reasons. So please go to our page, like us, follow us, and see you on the 27th. Have a good evening.